Okay, we are live now. Okay, hello guys, welcome to Global Perfusion Community. So today we have Abrar Alkamel, right?
Yes.
Okay, so she is going to talk on the topic that is myocardial protection and cardioplegia in cardiac surgery and during cardiopulmonary bypass. So you can start, Abrar. It's your time now.
Yes. Hello, everyone. I'm really happy to be with you today. My name is Abrar and I study perfusion. In this session, I will introduce some important points about myocardial protection and cardioplegia in cardiac surgery and cardiopulmonary bypass. Next slide, please. Yeah, today I will talk about many key points related to our topic. I will talking about the mechanism of myocardial injury, myocardial damage, and risk factors for myocardial injury. Also, we will talking about the goals and principles of myocardial protection, components of blood cardioplegia, and also cardioplegia delivery. The next slide, please. Yeah, myocardial protection is very important during cardiac surgery. Why? To avoid ischemic damage during aortic cross clamping. The aim is to create a still and bloodless field for surgery. And we have to know without proper protection, the patient may face complications as low cardiac output or multi-organ failure. Next slide, please. Yes, myocardial damage results from oxygen depth because of imbalance between oxygenated blood supply and injury demand. It will manifest as difficulty in separating from cardiopulmonary bypass because of ventricular dysfunction and low cardiac output and sometimes leading to multi-organ failure. During cross-clamp, coronary perfusion stops and it will oxygen supply cases and myocardial shifts to anaerobic metabolism and it will lead for increasing lactic acids and ATP depletion and it will also causes calcium overload, edema and irreversible cell damage. Next slide, please. Yeah, also we have some enzymes that called biomarkers. They are highly sensitive and specific for myocardial injury. These biomarkers are troponin I, troponin T, and creatine kinase. Almost all patients after cardiac surgery will have a rise in serum cardiac biomarkers and it will be different from patients to other. It's according to the degree of myocardial injury. Next slide, please. Yeah, we have some risk factors for myocardial injury: prolonged aortic cross clamp time, pre-existing acute ischemia, re-operations, combined coronary artery bypass cabbage and valve surgery at the same time, and also impaired pre-operative ventricular function. Next slide, please. Thank you. Yeah, we have some goals of myocardial protection. The goals of any myocardial protection strategy are to prevent or limit myocardial damage during perioperative ischemia and also maintain balance between oxygen supply and demand to prevent injury and also reduce risk of stunning infraction or low cardiac output post-operative. Next slide, please. Yeah, we have some principles of myocardial protection. Our principles is stop electromechanical activity by using diastolic cardiac arrest and using cardioplegia. Also, we have to lower metabolic through hypothermia. This hypothermia it will achieved by cold cardioplegia, ice packing, or cold pericardial lavage, and it will controlled by cardiopulmonary bypass. Also, we are using integrate cold blood cardioplegia is benefited for uniform cooling, and we also have to avoid and focus not to prolonged or excessive localized hypothermia. Why? Because it will cause additional myocardial injury. Next slide, please. Yeah, I said from our principle for protect myocardial, we are using blood cardioplegia. Okay, what is the components of blood cardioplegia? First of all, I want to tell you what does it mean. Cardioplegia solutions provide myocardial protection by using combination of three mechanisms. Our mechanisms is addition to cardioplegia solutions, myocardial hypothermia, and induction of chemical cardiac arrest. What we are meaning for cardioplegia additives? We are adding some drugs and some materials for to the blood to increase the protection of myocardia. The main aim of all cardioplegia solutions is to induce rapid diastolic arrest by adding some drugs on it, like electrolytes. Why we are electrolytes for blood cardioplegia? We adding electrolytes because they induce rapid diastolic arrest, and also we are using brucain. Brucain it's effective in stabilize the cardiac rhythm after cross-clamping, removal and reperfusion, and decreasing ventricular fibrillation. Also, we are using mannitol. Mannitol is added to increases the osmolarity and minimizing fluid transfer and intracellular edema. Also using albumin and glucose. It have also been added to some solutions to increases osmolarity and support cell volume and metabolism. Also, we are using main thing it's sodium bicarbonate. Sodium bicarbonate it will maintain pH system. Also, we are using magnesium. Magnesium is a very effective physically like antagonist to calcium, and it's added to cardioplegia solutions to block calcium entry into myocytes. Also, the second component is myocardial hypothermia. Myocardial hypothermia, we have a golden rule for it. Our golden rule is myocardial oxygen demand decreases with temperature, and we infuse of some warm blood cardioplegia before and after cold cardioplegia. It has been shown to preserve myocardial ATP levels. On this basis, some surgeons choose to administer a hot shot to cardioplegia. Why they prefer to use it? to releasing the aortic cross clamp and reperfusion the myocardium. It will help the myocardium to perfusion easily and making a good result. Also, we have to know that the benefits of cold blood cardioplegia is only around 10% more than the achieved by comparing cold and warm cardioplegia. Also, our third components of blood cardioplegia is chemical cardiac arrest. Cardioplegia solutions act by altering potassium concentration. It will suppress electrical activity and induce safe cardiac arrest during surgery. There are many kinds of cardioplegia that are using around the world, and it will be different from country to other and from hospital to other according of their protocols, but the main goal is always the same. On our it will be the same. I hope we can talk about this topic in the more details in other presentations. Yeah, and next slide please. Thank you. Okay, I said to protect myocardial we are using cardioplegia. Okay, how we can use it? What is the delivery of cardioplegia? Our goals during delivery cardioplegia is ensure cardioplegia reaches all myocytes to induce and maintain diastolic cardiac arrest. We have to focus on it, and we have three routes: antegrade, retrograde, and combination. Antegrade it will using by coronary arteries from putting the root canal to the aort according to the aort into the coronary arteries. It will inject it into the aorta proximal to cross clamp. It will be under pressure of 80 to 100 millimeters of mercury. In some cases, like incumbent aortic valve and severe coronary stenosis, it will be unequal perfusion. And in these cases, our goals it will not be good. So in these cases, we will using antegrade by coronary ostium. Sometimes we are using this coronary ostium during root and valve surgery. Why? To maintain our goals is to ensure cardioplegia reaches all myocytes to induce and maintain diastolic cardiac arrest. Also, we have the other route is retrograde. Retrograde, it will be using by coronary sinus. Coronary sinus is a system of venous myocardia. It will when we use retrograde is used when antegrade is ineffective, like some cases, for example, severe stenosis, reduced coronary artery bypass surgery, and acute myocardial infarction. It will be under pressure of 40 millimeters of mercury, and sometimes this will cause bloody film. Why? Because in coronary sinus we have the patient's vessels. This vessels is entered to atrial and ventricular of the heart, and it will cause bloody film and hemodilution. and we have to be focused on this point when we using it. And also, retrograde, it will be ineffective in some cases like persistent left superior vena cava. Yeah, and also we have the third route is combination. Combination, we will using antegrade and retrograde at the same time, used to maximize myocardial distribution and ensure fall protection. In some cases, the patients come to the hospital and her myocardial is have a big damage, and in these cases, we prefer to using antegrade and retrograde to be ensuring fall protection for myocardial. And also, as I said, there are many types and protocols of myocardial, and they are different from country to country according to protocols they are used. And cardioplegia, it's a big topic. Yeah, I hope we can talking about it in details, inshallah, in next or other sessions. And I'm so happy to be with you today, and I will be happy to hear your questions. If you have any question, you can ask me.
Okay. So guys, we'll start the question and answer session now. So if you have any questions, you can ask. So you can comment your questions in the comment section, and we'll pick the questions, and Abrar will try to answer the questions. Okay. So we have a question over here. Okay. So can you see the question?
No, I can't say it.
Okay, I'll explain it to you. So here is a question from Twinkle, and she wants to know about the graft from cardioplegia. So can you explain about
I
the cardioplegia from the graft?
I said to you the cardioplegia topic. The topic of cardioplegia is very long, and I don't explain it for today. So if you can relate it, you can say instead of me.
Okay, so we'll have a discussion over it in the next session. So we'll talk about it in detail. So here is the next question: how to make manual St. Thomas cardioplegia? So how to make St. Thomas cardioplegia? Can you explain about it? What are the components?
I can't hear you very well.
How to make St. Thomas cardioplegia?
It's according to the hospital, and it's using some drugs, as I said in the slides, like mannitol, like sodium bicarbonate, potassium, magnesium.
Okay, which cardioplegia do you use? Which cardioplegia do you prefer?
Blood cardioplegia.
Okay, but is it St. Thomas or Del Nido? Which one?
Thomas
Okay,
cardioplegia.
okay. So how do you make this solution in blood cardioplegia? In blood, how much amount you add according to
I
the weight?
what?
How much solution do you add in the blood according to the patient's weight
Yeah,
or the cardioplegia dose?
according to the patient's weight. Yeah.
Yeah. So how much do you calculate? How much dose do you calculate, and how much solution, how much cardioplegia solution do you add in that, in the
We
blood?
calculated according to patient's weights, and every 1 kilogram we using 10 millimeter.
10.
Milliliter.
You mean per 100 ml?
Yeah,
Okay. For 100 ml, how much solution do you add? So
What?
see, I'm asking you that for per 100 ml, how much cardioplegia solution do you add? Do you use the ready-made cardioplegia solution which we get in the market? Have you used it?
No.
Okay.
Can you answer this question instead of me?
So I'm asking you the St. Thomas cardioplegia or the ready-made cardioplegia which we get in the market, the ampoule, cardioplegia ampoule.
Yeah, we are using blood cardioplegia and taking blood from the patient and
Yeah,
putting some magnesium, sodium bicarbonate, and mannitol for it.
yeah, yeah. So how much do you add? Sodium bicarbonate and potassium and mannitol. How much amount you add? So what is the calculation for that?
I'm not sure.
Okay, fine. So you have not used Delnido cardioplegia. Do you use
No, no.
instead of St. Thomas?
Yeah, this in Turkey is just using blood cardioplegia, as I said, and also
Okay.
I didn't see more kinds of it.
Okay, so what is the time period for blood cardioplegia? Like for how long you can extend it? So
Yeah,
what is the second dose? Like at
yeah.
what
The
intervals do you repeat the dose?
The first dose, it will. We have two kinds. We have a long effective and short effective. Short effective, every 20 minutes we will we will give it,
Okay.
and the long one, the long effective one, it will be for 1 hour.
Okay. So the I want to know what is the long effective one cardioplegia like is it the same solution which you use for the
Yes,
Saint Thomas?
no, we don't using the same drugs, and
Okay.
in short blood cardioplegia short effective, we are using little drugs, and
Okay. So we'll go to the next question. We have one more question over here. Okay, so here is a question from Aisha Nadim. So she's asking, do you take autologous blood in cardioplegia? So do you have any like comments on this?
no.
Do you use autologous blood? So actually in cardioplegia, what we do is while we are on the bypass, cardiopulmonary bypass, we take the blood from which is going to the arterial to the patient, and there is a 1/4 line connected to the arterial line, and that blood goes to the cardioplegia delivery system, and the same blood is circulated in the cardioplegia delivery system. It is cooled, and the cardioplegia solution is added to that delivery system. Or there are different kinds of devices which we use for cardioplegia delivery. In India, we use Coles chamber and BCD system. So the solution, cardioplegia solution, is added to this system, these chambers, and it is cooled, and it is circulated, and it is given to the patient. So we use the same blood which is circulating on the cardiopulmonary bypass. Or sometimes, like for the Saint Thomas, we add it in the NS solution that is there, and it is given into the BCD system. Okay, so we'll go to the next question. So as you said, you use Saint Thomas cardioplegia, right?
What?
So as you said, you use Saint Thomas cardioplegia for
Mm-hmm.
every case.
Mm-hmm.
Okay, so here is a question: what is the difference between So first dose of Saint Cardioplegia and second dose of Saint Thomas Cardioplegia.
The difference between first and the second
Yeah.
dose of cardioplegia, the first dose it will be a high and of blood cardioplegia, and in the second dose it will have a half dose.
Okay. Half dose. Okay.
Yeah.
Okay. So we'll. Have you used HTK solution?
Have we use what?
HTK solution. HTK cardioplegia solution.
No.
Okay. So here is the next question. What is the temperature for cold cardioplegia?
Yeah, the temperature of cold cardioplegia at the first dose we are using warm blood cardioplegia, and the second dose it will be at the temperature of 25 24. No, it will be in a temperature of 4 degree.
Okay. Okay.
Yeah.
Okay. 4 to 8 degrees. It should be cool to 4 to 8 degrees.
Yeah.
Okay. So what is the temperature you maintain on cardiopulmonary bypass? The patient's temperature.
The patient's temperature it will be different from surgery to other, but it will be from 28 and 25, like this.
Okay. Okay. Fine.
It's different according to the operation and according to the patient.
Okay. So we'll have a detailed discussion on this topic in the next session. I hope
Yeah,
you will.
because this
Yeah.
topic, this topic is have a lot of details, and
Yeah.
it's different from country to other, and I think to talk about it just about cardioplegia without another topic.
Okay. Okay. Fine. So mostly we use this Delnido cardioplegia. So we use it for around 60 to 90 minutes. So usually we don't repeat the cardioplegia dose because it goes around 60 to 90 minutes. So we can easily finish a procedure which takes 60 to 90 minutes. If
Yeah.
required,
It's
yeah, if required, if the procedure goes beyond 90 minutes, we'll repeat the dose of cardioplegia. But mostly we finish it within 90 minutes.
Yeah, I said yeah. It's according to the protocols. Yeah,
Yeah.
in long effective, and we have the short effective cardioplegia. Yeah, in long effective cardioplegia, we don't repeat it the dose, and in short, we have to repeat.
Okay. So there are a few more questions. Can you see the question?
Why using second dose of cardioplegia like of the dose? Yeah,
Okay, so here is a question from Ravi. Uh, so why using second dose of cardioplegia like of so? I think the question is not properly asked. So can you ask the question again? Can you
like
comment?
yeah, we said that if we are using a short effective cardioplegia, we have to using second and third dose because to maintain the
Yeah.
operation to maintain the operation. If we don't use it and we are using a long effective cardioplegia, we will not need it to repeat the dose.
Okay, fine. So here is one more question from Aisha. What is the HTK solution? So I guess most of them have not used the HTK solution. So do you have any idea about it?
This solution, I don't have any idea about it because we didn't use it
Okay,
before.
fine. So this is a solution which is used for long duration procedures. So it is given for long duration procedures and complicated procedures. The arrest time is for around 2 hours, and it can go beyond 2 hours also. Usually, the St. Thomas cardioplegia we repeat after 25 to 30 minutes, and the Del Nido cardioplegia we repeat after it. It depends. It goes up to 60 to 90 minutes. So we can repeat the Del Nido after 90 minutes. But in HTK solution, we can arrest the heart for a long time, around 20, around for a duration of 2 hours, and we'll have a deep discussion on this topic because STK solution is not commonly used. It is not used for short duration procedures. It is used for long duration and complicated cases like heart transplants. So we'll discuss about it in the next session, or we'll have a special session for this topic. So, so here is one more question. What is Cabilite solution and how do we use it? So do you have any idea about Cabilite solution?
No.
Okay, fine. So Cabilite solution is just as a solution which we use in the cardiopulmonary bypass for priming the circuit. So there are different types of solutions. There is Plasmalite A, and commonly used solutions are the normal saline and Ringer's lactate, which we commonly use, which is very commonly available, I guess, in every country. And there is also Plasmalite A solution, and there is Cabilite solution. And also sometimes we use Voluin solution and Hesteril solution. So Cabilite solution is nothing but a mixture of like there are different components in it, magnesium, and I'll show you the detail. I'll share a detailed video on it. So right now I don't have the photo or the components list. So it is a solution as common as like we used the RL, that is the Ringer's lactate, or the NS and Plasmalite A volume solution. So it is one of the kind which is used for the priming of the cardioplegia this cardiopulmonary bypass circuit. Okay, so we'll wait for some time. If there is any questions, you can ask. Okay, so here is one more question. Initially, we are giving 20 ml per kg of cardioplegia. Then we are repeating the dose. We was 10 ml per kg. Okay. So why giving like that? What was the reason? Okay. So the question is, first dose it is given 20 ml per kg, and the second dose is given 10 ml per kg.
In
So
the,
what is the reason?
what is the reason for
Yeah.
using it?
Yeah. Like the second dose is usually given half dose. So what is the reason?
In the first dose, we are using a lot of blood cardioplegia because of myocardial of electric of the myocardial activity is very effective, and we needed more drugs for stop it. And at the second and the second dose, we need half dose because the myocardial activity is slowly, not
Okay,
like
okay.
effective.
Okay, and also the duration uh, also the duration required is not more for the second dose. Usually, the first dose is given after 30 minutes, and the second dose, which we repeat after 30 minutes, it extends the arrest time for around 25 minutes. So within 20 minutes, we will release the clamp. 15 to 20 minutes after the second dose. Are you getting what I'm telling? So the first dose, it is the like it is around 20 ml per kg, and the second dose is 10 ml per kg. So like the first dose is for 30 minutes, and when we repeat the second dose, we usually release the clamp after 15 minutes if the procedure is not going for a long time, or it is not for a long duration. Okay, we have one more question here. Which route of cardioplegia delivery system is more common? So the question is quite confusing now, because
The more common of route
okay,
of
just a
cardio
minute.
is antegrade.
Okay,
Antegrade cardioplegia is the more common.
yeah, antegrade cardioplegia delivery or retrograde delivery, which is preferred more?
Antegrade is the
Okay, and what about the retrograde cardioplegia?
retrograde cardioplegia. We can't use it. If we use retrograde cardioplegia, it will not be enough to our goals to maintain the infusion for myocardial.
Okay, so can you just give an example in which cardiac cases is the retrograde cardioplegia used?
Yeah, as I said, in some cases like severe stenosis, aortic stenosis, we are using retrograde cardioplegia, and
What about
in
what?
about also in acute myocardial infarction, we are using retrograde.
Okay, I think what about what about regurgitation, aortic regurgitation? I think this retrograde cardioplegia is more beneficial in regurgitation, aortic regurgitation cases, because when we give the antegrade cardioplegia, if the valve is having regurgitation, the cardioplegia will not be effective. If the aortic valve is having regurgitation, and if we give only antegrade cardioplegia, the cardioplegia might not be that much effective.
Yeah,
So we give this retrograde cardioplegia so that there is complete myocardial protection.
and also we can use a combination for
Yeah,
antegrade retrograde. It will maximize the myocardial protection. It will be very good for these cases.
okay, fine. Okay, so we'll wait for 2 minutes. If there is any questions, we'll see. Okay, so here is one more question from Aisha Nadim. According to my knowledge, the route of cardioplegia depends on surgery and requirements. So is it right?
Using uh, the route of cardioplegia is according to the surgery and according to the patient's disease and the cases. Yeah,
Yeah. So mostly the cardioplegia depends on the surgery or the procedure which we are going to perform. So if the surgery is a bit complicated, or if we need long duration cardioplegia, for example, if we are doing a Bental surgery where we need the cardioplegia for long duration, so we'll we'll use the antegrade and the retrograde also, because there is regurgitation of the aortic wall, and we need to replace the wall also, and also the ascending aorta. So it is a big procedure, and if if only antegrade cardioplegia is given, maybe the cardioplegia will not be enough. It will not be delivered adequately to the myocardium. So there is the second route, which is the retrograde, which we give from the coronary sinus. So these two options are there for us for the better myocardial protection. Usually, if there is no regurgitation, or if there is the like, if it is a small procedure or a single wall procedure like mitral wall or some congenital disease, atrial septal defect, or any small procedure, we can only give antegrade. But if there is a long procedure, we should definitely prefer this retrograde cardioplegia, because this will enhance the myocardial protection, and the outcomes will be good after the surgery. So we have one more question over here. What is the pressure and flow of antegrade and retrograde?
The,
So
pre-
at what? Yeah.
the pressure of antegrade is between 80 and 100, and the pressure of retrograde is 40 millimeter of mercury.
Okay. 40 mmHg. So the antegrade pressure is, what you said is how much?
80.
Okay, 80 to 100 mmHg, and for retrograde it's 40 to 60.
Yeah.
Okay, we have one more question. So do you have any idea about microplegia?
About what?
Microplegia.
Microplegia.
Yeah.
No.
Okay. So we have one more question from Faiza Khan. What is the best myocardial protection technique? Blood cardioplegia or crystallite cardioplegia?
Also, it's according to patients, and blood cardioplegia, it will reduce the dilatation of the blood, and crystal white cardioplegia, it will increasing the dilatation of the blood for the patient.
Okay. So according to me, I would say that blood cardioplegia is best,
Yeah.
as it also has the oxygen, and which is very beneficial for myocardial protection. Okay. So there is one more question. Is cardioplegia solution, so does the cardioplegia solution affect the ABG of the blood?
Yeah, it's affected of it because in cardioplegia solution we are using some electrolytes, and it will be change the ABG for the patient, the electrolytes of the AB for the
Yeah.
patient, like potassium.
Yeah.
It will increase.
So usually after giving cardioplegia dose, we commonly observe that when we take the sample for ABG, and when we get the ABG report, so
Yeah.
we will see that the potassium levels are increased because we have the main ingredient in cardioplegia is the potassium. That is the main ingredient which we need to arrest the heart. So after the cardioplegia dose, usually the potassium levels increase.
Yes.
Okay, so I think uh, this is going to go like okay. So we have one more question over here. How to manage myocardial stunning or cardiac dysfunction after CPB?
We will manage it by electrocardiography, and we will know how the solution of myocardial fraction, myocardial what myocardial function, and also by uh, the test of biomarker for troponin and creatine kinase, and
Okay.
we will know the state of myocardial.
So how do you manage? What is the treatment for myocardial stunning and
Yeah.
cardiac dysfunction?
Uh, by supply oxygen for the patient and using some drugs to support myocardial function.
Okay, so basically, while coming off bypass, if you notice there is myocardial stunning or cardiac dysfunction that is caused due to inadequate cardioplegia delivery or inadequate myocardial protection, we may need some inotropic support for the heart, like adrenaline and dobute, and if required, if the cardiac ejection or the cardiac output is less, we may switch to vasopressors for better pressures, because if there is uh, myocardial damage, if the myocardial protection is not sufficient during cardiopulmonary bypass, it can cause myocardial stunning and cardiac dysfunction. So to overcome this, usually while coming off bypass, we may require a high dose of inotropes, and we should also check the potassium levels, calcium levels, and uh, we should do the required correction. And also the temperature is very important for myocardial protection. So to avoid myocardial stunning and cardiac dysfunction, the myocardial temperature is very important, because while delivering cardioplegia, if the cardioplegia temperature is not adequate, it can also cause myocardial damage and cardiac dysfunction. Okay, so one more question. So, what is the temperature of hot shot cardioplegia? Actually, it is not cardioplegia; it is hot shot. What is the
Yeah.
temperature of hot shot, and how do how to avoid reperfusion injury by maintaining temperature?
The temperature of hot shot, it will warm it about 37 degree.
Okay.
And what is the second question?
How to avoid reperfusion injury by maintaining temperature?
By controlling temperature of the patients by cardiopulmonary bypass.
Okay, so I'll give a short I'll explain it in my own way. So the temperature for the hot shot is around 37 degrees, but the hot shot uh, time is very important. Means the patient's temperature and the hot shot temperature should not have a huge difference. We can't give, like, we should not give the hot shot when the patient's temperature is around 30 degrees, the circulating blood temperature is 30 degrees, and we can't directly give hot shot. So we need to maintain the temperature at least around 34 or above 34 to give the hot shot to avoid reperfusion injury. Because if we give the hot shot at 37 degrees and the patient's temperature is 30 degrees or 32 degrees, there is a huge difference in the temperature gradient of the patient's temperature and the hot shot temperature. So it may cause reperfusion injury because we are suddenly giving a blood which is having a high temperature. So we need to maintain the temperature gradient while giving hot shot. So the temperature gradient uh, should not extend beyond limit. It should be minimum. Like if the temperature of hot shot is 37, the patient's temperature should be 34 or 35. So while rewarming, we can give the hot shot. If the patient is cooled and the temperature is around 30 or 32 degrees, we can't directly give the hot shot. We should keep in mind that the temperature should reach around 34 degrees before we give the hot shot. Okay, so we have one more question. So this will be the last question. What is retrograde cardioplegia delivery system and flow, and how it will come out of the reservoir?
The retrograde cardioplegia delivery system is via coronary sinus. Yeah, and it will be under pressure of 40 to 60.
Okay. Okay, so the retrograde cardioplegia is given through the coronary sinus, and it doesn't come out of the reservoir. Actually, see, as we give the antegrade cardioplegia from the aortic root, same way we have a different cardioplegia needle for the retrograde cardioplegia delivery system. So the retrograde cardioplegia is given through the coronary sinus. It goes through the coronary sinus and it comes out from the coronary root in the aorta, and it comes and it is sucked back from the root vent. So it is in a retrograde way. So antegrade is from the aortic root, from the aorta, and the retrograde is from the coronary sinus, from the RA side. So it is like a reverse method. It flows in a reverse direction in the in the coronary arteries. So one more question: in which cases hot shot CP is used?
We're using it in the cases when we're using blood cardioplegia in all cases.
Okay, so um, the hot shot CP is not actually, it is not used to arrest the heart. It is while rewarming
Yeah,
before releasing the
before
clamp.
removing the myocardial.
Yeah,
Yeah.
yeah. So before releasing the clamp, we give the hot shot so that the cardioplegia dose which we have delivered should be flushed out from the myocardium and from the coronary arteries. So we give this hot shot to flush the cardioplegia which is remaining in the myocardium or the coronary arteries. So this hot shot goes into the coronary arteries and into the myocardium, and it pushes the cardioplegia or the potassium which is remaining in the myocardium, and the heart starts beating. Like it is like, mostly like as a normal blood solution without potassium. We can just add sodium bicarbonate to the hot shot and xylocard, lignocaine, magnesium to like support the myocardium, to prevent the reperfusion injury. We should maintain the temperature gradient, and we can start the heart before we release the clamp. Okay, so one more question: dose of hot shot. So, is there any fixed dose for the hot shot?
I don't think so.
Yeah. So there is like the hot shot doesn't have a fixed dose. When we give the hot shot, we just maintain the temperature of the hot shot, and we give it till the heart starts beating, or if, until there is activity. So once the heart starts beating, or once the activity is started, we can stop the hot shot and we can release the clamp. Okay, so I think this is enough for this session, and we will uh, have a deep discussion on this myocardial protection topic in the next session. And thank you for
We have
your
about
presentation.
the types of cardioplegia because it's a long topic.
Okay, so thank you guys for joining, and thank you once again, Abrar, for your wonderful presentation. And we hope we'll join with you again for the next session, for next discussion, and all the best for your future.
Thank you.
Yeah, thank you, and see you guys in the next session.